E passo desde já a palavra a Melita Jacob, que é co-moderadora desta sessão, para nos contar mais sobre os princípios que estão por trás desta série de webinars que realizaremos em 2025 e 2026. Melita, over to you.
Hello, everybody. Thank you so much for joining us. And this is the immediate test to see if your closed captioning translation worked. We in WHO Regional Office for Europe are really excited to implement this project with you and to learn from it as well. We have designed this webinar series that we're going to deliver this year and next year with very specific principles. We want this to be an opportunity for a two-way conversation to capture the voice of those of you implementing integrated care in Portugal and to channel them to those who are making policy decisions. We have selected the topics for these webinars based on your demand. As you remember, we have polled you several times in the preparatory phase for these webinars, and also aligned with the main topics that we're working in this project: governance, performance monitoring and measurement, developing primary healthcare-oriented pathways, shifting to a population perspective, and integrated digital and data frameworks. We will be, in each webinar, we will be looking at international experiences to really capture some of the frontline practices in Europe. But we will always, most importantly, pick up 2 or 3 experiences from local health units to keep our finger on the pulse of your implementation successes and implementation challenges. We will always start with a plenary conversation, but then we will move to breakouts to make sure that we hear your voice, and we encourage you to stay for the whole time and to be active and participate. We will be starting from today using a WHO-designed artificial intelligence-based tool to capture as many voices as we can, and we will analyze those, and in subsequent webinars, we will feed it back to you, as well as we will feed it to the policymakers, decision makers in a structured manner. Our ultimate goal with this webinar series is to develop a culture for a two-way conversation where the voice of practice informs policy in a systematic manner. And with that, I would now like to invite Simon Drees, who's Policy Officer at the European Commission in the DG Reform. Simon, over to you.
Thank you very much, Melita. Good morning, everybody. I'm joining you today from Hungary, where I'm attending a project meeting on interoperability of health data, but I couldn't miss the opportunity to also welcome you on behalf of the European Commission's Reform and Investment Task Force. As many of you know, this project is funded under the Technical Support Instrument of the European Union. And we are very glad that with this webinar, we are officially kicking off things in this series. Melita has already said everything that one could really say, but I would just like to add that we are really looking forward to hearing your feedback after these webinars, because this project is really for you. It's to support you in your daily work and in your practice, and we want to make this as useful for you as possible. I will unfortunately not be able to stay with you today, but I look forward to joining all of the future webinars. And I would like to thank you for taking the time out of your busy schedules to attend, and also to our international speakers for sharing their expertise. I think this webinar series really is a very great opportunity to combine your experience and international good practices, and hopefully also our speakers will have something that they will carry home from your expertise. So thank you very much, and I wish you all the best for this session today.
Thank you very much, Simon, for your words and for being able to join this moment. Passando então para este webinar em particular, e tal como o Simon disse, a ideia é juntar não só a experiência internacional, mas também as experiências nacionais. E este é um webinar chapéu que aborda alguns tópicos importantes sobre abordagens integradas dos cuidados e que depois, nos webinars seguintes, vamos poder explorar em maior profundidade. E espero, por isso, que desperte o vosso interesse. Melita, over to you.
Today, we will listen to 3 international presentations from Spain, from the United Kingdom, and from Finland. And afterwards, we will pick up 2 of the local health unit experiences before going out to the breakout rooms. So let's jump into it now. And I have the pleasure to introduce Anne Fulaondo Zabala, who is a scientific director at Biosistemak, Basque Country, Spain. And Anne will share with us experiences about the importance of population health management for designing integrated care models. Anne, over to you.
Thank you very much, Melita. Thank you very much for giving me the opportunity to share with you some insight that we have gathered in the Basque Country, which is a small region in the north of Spain. So I will share my screen so you can, hopefully you can see everything. So the idea is that very briefly, I can explain to you the journey that the Basque Country, let's say, had in the last 14 years, 15 years, more or less, to address the needs of complex chronic patients. So first of all, I would like to show you this journey towards integrated care and the, let's say, the huge or big milestones that we have reached through this journey. So first of all, I would like to emphasize that in the Basque Country, we had what we call a structural integration. That means that we created 14 years ago what we call integrated healthcare organizations. That means that there is a common governance body for the primary care centers and the hospitals in the same geographic area in the Basque Country. I also would like to stress that we have deployed a quite comprehensive and powerful e-health strategy in our region, with pivotal elements that mainly are the unified electronic health record that all the professionals can access to, the electronic prescription, the personal health folder for the citizens, 24/7 nursing call center, and so on. I will give some details later on this. Another huge achievement that we had is that several years ago, we deployed the population-based risk stratification approach in the Basque Country. That means that all individuals in the region are labeled with a signal in the electronic health record, and we are classified into one of the risk strata based on the case permanent stratas. Then, and this is something that I will talk about a little bit later on, is that we have the structural integration, but also what we call functional or service integration. We deployed several integrated care pathways, being one of them that of the multimorbid patients or complex patients. Of course, for each of these patients, we do have personalized and individualized care plans that are created, developed, and shared by primary care professionals, and they can be discussed with the patients and caregivers as well. And finally, another big achievement is that we do have the contract program, which orients the financing here in the Basque Country, which is an NHS model. And there is part of this financing that is linked to the integrated care provision. Just some information about the population-based risk stratification. But I know that in Portugal, you already have something similar to this. And this is something that was deployed several years ago. And this stratification tool, let's say, uses or is nurtured by different data sources from the healthcare provider, sorry for this, but also for the ministry. We also have automated and fast data extraction process in place, and we use several variables to stratify all the population in the Basque Country. We use a predictive model. Historically, we used ACG Grouper, but last year we started developing in-house algorithms, and this is something that is used today. And this stratification is run annually. And of course, the output of this stratification, risk stratification, is that based on the foundation that the healthcare costs are equivalent to the healthcare needs, we have translated the predicted cost of each individual in the Basque Country to a predictive index. So the higher the costs are for an individual, the higher the predictive index is. So we have all the individuals in the Basque Country with a level that is visualized in electronic health record. And of course, this is what we use to assign individuals to care pathways, integrated care pathways if needed. With regards to the pathway for multimorbid patients, which is maybe the core of this talk, is that, as I said at the beginning, we have this structural integration, and all these integrated healthcare organizations have deployed care pathways for multimorbid patients to try to ensure the continuity of care of this population. The multimorbid patients are identified and labeled by the certification tool. And this population represents the 5% of individuals with the higher predictive index, just in the top of the pyramid. The main care providers for this type of patients are those of the primary care setting. The case manager belongs to the primary care setting. And in this pathway, this is a diagram that you can see. This is the care pathway for the multimorbid patients. All the phases, settings, actors, roles, functions, even the decision-making and referral criteria are very well defined for this pathway. And as I said, primary care actors or professionals are leading this pathway. As I said at the beginning, of course, multimorbid patients, they have individualized care plans created by primary care professionals and are served with hospital care professionals. And if needed, they have internal discussions, but also encounters with patients and caregivers to really develop and create these care plans. And one important thing that we have faced during the last years is that for a complete deployment of this pathway in the whole region, the facilitator role is really key. Based on implementation science and change management foundations, I would say training, communication, and monitoring activities have been crucial for this successful deployment of the care pathway. Here, just to let you know, the elements of the e-health ecosystem that we have in our region. As I said, we have several things. And for the multimorbid patients, this is what we have active in our region. We have the electronic health record. There is a nursing health record embedded in the EHR. Electronic prescription is also crucial because this type of patients are polymedicated usually. To try to organize and structure all the activities that should be performed by healthcare professionals, we have program managers, a kind of a planner, digital tools, I mean, everything helped by technology. And we also have some solutions and services that are directed to the citizens, to the patients, such as telemonitoring services, video consultation. We also have the 24/7 nursing call center, e-health school to try to promote patient empowerment, the personal health folder, of course, with all the information that is integrated in the electronic health record is visualized in the personal health folder, and health apps such as My Treatment app. And all of these technologies that can be used by patients can be used also by caregivers if needed. If a patient cannot use the technology offered due to the digital divide, caregivers can access to it and contribute to the care provision. And also if patients, maybe because they are younger or have a high degree of digital literacy, they also can use all these solutions. They are offered by the healthcare system. And finally, just some learning that we have gathered during this process of deploying integrated care in the Basque Country. First of all, it is crucial that we involve and empower stakeholders from the very beginning, nurture cooperation, create a common vision, and also try to boost ownership feeling. Understanding the context and building on existing experiences is also very important. So to do that, we need a comprehensive situation analysis to detect local needs, because this might differ a little bit from one province to the other one or small parts of the country, and recognize the capabilities and resources available. We are also working hard on the inclusion of the value-based healthcare approach, equity lens, and journey perspective in the integrated care approaches that we are deploying in the region. The power of the information is something that we need to emphasize. We need to define outcome and performance indicators, mobilize data sources, and of course, strengthen the analytic at work. We need to know what we are doing and the results that we are getting. To deploy these integrated care approaches, it is also very relevant to have a well-structured, straightforward, and adaptable implementation strategy, what I call before this facilitator role. And finally, we need to learn not only from the successes, but also from the failures, follow a learning by doing principle. So this is all from my part. Thank you very much. Obrigada.
Thank you very much, and it is always a pleasure to hear you and to hear the experience of the Basque Country that some of our audience already knows from the participation in the Jade Care Project. Vamos passar já de seguida para o Dan Alton, que é o Conselheiro Clínico Nacional no que diz respeito às questões da gestão da saúde da população no NHS inglês. Dan, thank you very much for participating in this webinar, and over to you to share your experience. Thank you.
Thank you very much, Vanessa. I will endeavour to share my screen. Hopefully you are seeing that. Is that working? Can you see a presentation?
Yes.
Fantastic. It should say moving towards neighbourhood-based care in England.
But it's not in presentation mode.
Right. Is that working now?
Now it's perfect. Thank you.
Perfect. Great. Thank you. So I'm Dan Alton. I'm a GP. I work in Berkshire in England. I'm National Clinical Advisor for Population Health Management at NHS England. And I work locally in Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board as Chief Clinical Information Officer. So I've seen this from a national, a local and a very local perspective of my own GP surgery. And what I'm going to be talking about for the next few minutes is how we've been endeavouring to move towards neighbourhood-based care in England. And I think it's worth briefly explaining where we are as a healthcare system. I won't go into much detail about the NHS, but like many countries across Europe and more widely, we are facing a challenge from an ageing population with increased frailty and complexity and a squeeze on the funding we have to support our population's health and well-being. We have a complex set of organisations delivering services. Across England, we have 6,200 GP surgeries, 215 different trusts. These are the hospitals that deliver services, the community trusts that deliver care to patients within the community. We have groups of GP surgeries forming primary care networks. We have local government running social care. We have ambulance trusts, which are responsible for the ambulances. And then we have 42 integrated care systems. These are organisational networks of organisations that cover the country that are running healthcare locally, split into 7 regions. Suffice it to say, it is complicated and it is at times quite fragmented. And one of the strategies to try and bring integration was to create the concept of integrated neighbourhood teams. These are teams that cover around about 50,000 population level, and they can work together across those organisational boundaries to look at the population health needs and address those needs, working with populations, communities and patients in a way that can be achieved in a very locally embedded level, bearing in mind that lots of different local areas have lots of different needs and ways of working. So what does this mean in practice? Well, essentially, it's about getting around a virtual table, looking at the data as well as the data we have on experience of our population, and from that data and experience, gaining some insight into population groups and their needs. And who sits around this table? Well, everybody. all the stakeholders who have a part to play in the health and well-being of populations. And this includes voluntary sector organisations, it includes analysts to support the data analysis, it includes local government, and it includes most importantly, patients and communities. And in terms of developing this neighbourhood-based care approach, this is a busy slide, but it really shows the kind of people on the left who would be as part of this integrated neighbourhood team. And this team looks at our population in terms of a population pyramid with three main aims. For the lower part of the pyramid, less complexity, most patients who are not regularly needing care, it's absolutely important to keep them as well as possible. And when they do need care, to ensure that this is streamlined and provided in an accessible and suitable manner. For those people in the middle of the pyramid who are suffering long-term physical and mental health conditions, we need to keep them as well as possible. We need to provide a joined up approach to their secondary prevention to make sure that they do not get more unwell. And we need to ensure that they can remain economically active as long as possible. Being in work is beneficial to not just individuals' mental and physical health, but also society. And at the top of the pyramid, those people in our populations with complex needs, we need to provide a much more proactive, personalised approach with a wraparound multidisciplinary team being able to respond rapidly to their needs and keep them as well as possible. And in order to do this, we have used various segmentation approaches. So using population health management to initially segment our population and then tailoring interventions to the different segments. And this is the Johns Hopkins adjusted clinical grouping approach, which in this slide gives an example of the kind of interventions that will be developed locally for the different segments based on their need. And there isn't time to go into a lot of detail on these, but you can see that essentially the principle is we're nuancing pathways, we're adjusting pathways dependent on the population segment need, but also what is available locally. So this isn't defined at national level, but this is co-designed and co-produced at local level with partners like the voluntary sector, community leaders, community action groups, local government, and the health and social care system to be able to provide those needs, what is required at those need levels, nuanced to local need, local population demographics, and local population available services. I'm just wanting to focus in the last couple of minutes on one particular example, which is at the high need group, that group which includes high complexity patients. When we look locally at this cohort of the population, like in many, many places, we found that there was a high need group identified who had extremely complex needs from both primary care, general practice, secondary care, social care. They often had a number of wider determinants of health at play. For example, issues with housing, issues with loneliness, and multiple other issues that were beyond the scope of what the NHS, what just health could deal with, but did need a coordinated, integrated intervention. And so we developed, local to me, a multidisciplinary team. Patients were proactively identified from that high need group, or they could be referred in by any clinician. And this team of multidisciplinary professionals, not just in health and social care, but the voluntary sector and beyond, went through, with the support of patients and their carers, reviewing what those needs were in more detail. And just as an example, in 20 months, 566 patients went through this process, and we did see a significant reduction in their A&E attendances and non-elective admissions, unplanned emergency admissions. We were able, with this process, by identifying that cohort within the data and adapting a multidisciplinary team approach to their needs, to keep them at home, healthier for longer and out of hospital. And that's what patients and the system really needs. Just a slide on governance to end. As I've mentioned, this really does need to be locally defined in our opinion, hence the idea of having integrated neighbourhood teams based at a population grouping of about 50,000. But there is infrastructure that's needed, including linked data. We have a lot of data in England. We have a lot of computer systems being used in health and social care and beyond. By linking all those systems together, linking the data within those systems, we can get a much more accurate impression of where our population is and what those different need groups are. And as I mentioned, it's really important to have very strong patient-citizen representation in this process. Often we can start designing systems and interventions, but unless we understand the lived experiences of our patients and citizens, including some data on those experiences and patient representation on those key groups that are making decisions, we often end up designing something that doesn't quite work. What we found is if we have strong patient representation on those boards, committees, planning, groups, then it seems to work better, apart from being the right thing to do. So that was a real whistle-stop tour of what we've been doing to implement integrated neighbourhood teams. We're at the beginning of our journey, but hopefully we can update you as we get further into this journey. Thank you very much.
Very good. Thank you so very much, Dan. I think you made a very strong case that we really need to move away from one-size-fits-all approaches. And the more we tailor, the more we use data and participation to do that, the better care we can provide, but also that's the fiscally responsible way to go. So thank you very much for that. With that, let's jump into our third example from Finland. And I have the honor to invite Sari Raassina, who is a senior ministerial advisor from the Ministry of Affairs and Health, to share with us Finland's approach to integrated care. Sari, over to you.
Thank you. I was a bit confused because my operator denied me access to Zoom, so I'm a bit kind of and hopefully, and finally I'm here.
It's great you're here. Let's jump into it. Very good. Okay. Welcome.
And, can you share my slides from there, or do I do it myself?
We are going to do it for you. You can get going.
Okay, thank you. So my name is Sari Raassina, and I'm a senior ministerial advisor, and by basic training I'm a medical oncologist, but my responsibility in the ministry is basic and primary health care. And I try to be very quick because I have lots of information for you from the happiest country of Europe. And thank you both for your excellent presentation previously. And I try to add some more into that field of integrating policies, integrating services for our people. But next slide, please. In Finland, we did a huge organization reform 2 years ago, a bit more than 2 years ago, but we planned for this reform for over 20 years. So these changes are not very quick, but now we have totally integrated organizations in Finland. So we changed from municipality-based organizations to well-being county service-based organization, and now these new organizations are fully functional, and they are doing all the operative work. Next slide, please. Before you can actually plan a huge reform that is aiming to integrate the services, you need to have some kind of a narrative, some kind of a national objectives of where you want your healthcare and social services to go to. And fortunately, in Finnish politics, in national politics and also in local politics, these objectives are very well shared among all political parties in Finland. So that is not the issue in Finland. So it should be easier to make a reform when you share your point of view. But anyway, even though the basic objectives are shared, the means how to achieve them are a bit different from the different fields of politics in our society. Next slide, please. So we have integrated governance. We have integrated governance also in our national level. So the ministries are working together with legislation and also guidance for these well-being service counties. And well-being service counties have autonomical position in our legislations, and they have elections, and the new elections are coming in 2 weeks. So you can understand that this conversation is going very in high. How would I say? The feelings are a bit high at the moment. How the services are actually functioning in different areas or different counties. But in these elections, new bodies and for administration for these counties are elected from each area, and because they are autonomic, they have their own way of organizing their administration and also the services. But there are common standards that they need to take account when they are organizing and producing the services. Next slide, please. I will go this through very rapidly, and you have the slides, so you can go through with the details later on. But when you want to integrate services, you need to also integrate funding. And that is one of the most important things in our reform, so that the funding comes from the national government, and it's shared to the counties with certain measurements, certain counting systems. The counting is done by the amount of population, and also there are variables of how this total funding decided by the national parliament is divided among the counties. They also need to cooperate with special services, so that these 21 counties, they form 5 collaborative areas where they produce very special tertiary treatment and care. Next slide, please. And then you need to have integrated and interactive government guidance. And this is a cooperative work we do every single day from the ministry to the counties. We have ongoing negotiations and meetings and working groups where both information and guiding is shared with these counties. I'm sorry, I'm always a bit confused saying counties, because we use in Finnish language we call regions, but in European language region means a different thing. So this county is something that we don't use in Finnish language. So that's why it's so difficult for me. Sorry about that. But the next slide, please. To achieve integrated systems, you need to share the objectives, you need to share monitoring, and you need to, in a way, have some kind of a, how would I say, logic in the strategies and plans that are made locally. And for us as a ministry, we need to have coherent information and to be able to make analysis from each of these counties separately, so that we can make some kind of a decision making up here in this ministry level. But this is on working process, and we are developing all the time these monitoring systems and try to make them similar in each and every county that there exists. Next. And finally, on the basic level, we have integrated and personal care coordination to all the levels and also to the social services. And we have integrated the services also with the services that are provided by the municipalities, like education and cultural and that kind of civil society systems that we reproduce in Finland. So these counties work together with the municipalities in the region so that this cross-sectoral integration can be done as well. Next slide, please. Okay, these two are my final slides. It's a journey. If you look at the points down there, we have started in the early 80s. So the digitalization has started in the beginning of this century. Like in 2007, we have provided a service called Kanta Services. And that is developing so that now all the prescriptions, for instance, all over Finland, in every single producers, whether it's private or public organizations, all the prescriptions are going through Kanta Services, and people can interactively use them. And there is data of personal data that every single healthcare or social professional can use. And if you look at these lines there, and next slide, please. And the political journey has been even longer. This wasn't built in one day. And now we have a fairly good system that but still needs to be, how would I say, developed every single day. It is said that you can't make miracle in a day, but in a decade or in 100 years, you can actually make a miracle. So don't be upset if things are not working fast enough and easily enough. You will have your time, and you must pay attention to your local citizens' opinions also, which way these systems, which way these services should be developed. Thank you for your invitation to share these thoughts with you.
Thank you very much, Sari, for sharing your experience from the happiest country in the world, and how does it work, and how much time did you took to plan all of the things that you are now implementing. Because we are running out of time, e porque estamos a ficar quase sem tempo, queria só fazer aqui 2 ou 3 comentários, e que no fundo é a importância da utilização dos dados, e nós temos muitos dados, muita informação em Portugal, e a importância de utilizar esses dados, essa informação para tomar boas decisões, para nos ajudar sobre aquilo que são os melhores caminhos. Também partir das experiências que já existem, não é preciso inventar a roda, não é preciso começar do zero, podemos construir a partir daquilo que nós já temos. A importância também de desenhar em conjunto com os vários intervenientes, tal como o Dan dizia, de forma a que isso funcione melhor, e da experiência do Dan isso funciona melhor. E, por último, esta questão de trabalhar ao nível local para ir ao encontro das necessidades específicas de cada local. And Melita, I will turn over to you for the next step. Thank you. Thank you all very much to our...
Indeed, thank you very much, dear panelists, for joining us. And to our audience, I want to apologize a little bit. This is our first webinar, and we packed it so much with content that there isn't much time to ask questions. But I encourage you to use the chat. Our speakers are with us. put your reflections and questions there, and then we will get to them. And from the next webinar onwards, we will make sure to leave space for your questions and inputs as well. Before we go to our local health unit presentation, I would like to introduce the AI tool that WHO designed. I would like to ask the team to pull up the slide with the QR code that our participants can scan. And if you take your mobile devices out and you scan this QR code, it will take you to an app that is designed by WHO. You're going to be asked to provide your name and where you work, as well as your email address. But rest assured that none of us can connect your response to your name. It's absolutely anonymized. The question is asking you, what are some of your successes as well as struggles in putting integrated care in practice and primary healthcare oriented pathways into practice in Portugal? And you will see that you can submit 3 responses. This can be very, very long. You can write us a novel. There is enough character space. And what this app does is it allows us at the back end to provide prompts and analyze your responses from whichever perspectives we are interested in it. So you don't worry about that. You just share with us the narratives, the successes and struggles you're facing in implementing integrated care and primary healthcare-oriented pathways in Portugal. When we return to our next webinar, we're going to start by providing you feedback, what we have heard from all of you. This app has served us in WHO very well in public consultations, where time is really limited to give everybody the floor and the microphone. But this way, we can make sure that all of your voice is heard and not just those people who will actually get to speak in the breakout sessions. If you're not able to scan this QR code, my colleagues are pasting the link into the chat that will also enable you to open it in your computer, which make it more easy to provide longer texts. We're going to leave this open until the end of the day because time is very tight here. So we encourage you, if you don't manage to put your responses in now, please use the time after the webinar until the end of the day to come back to us. And I think with that, let's jump in to hear from our 2 local health units who prepared for this webinar to share their experiences in this topic.
Passamos já de seguida, então, à Unidade Local de Saúde Barcelos Esposende. Quem vai apresentar é o José Calheiros, que é médico e interlocutor local para a estratificação pelo risco ao nível local. José, passo desde já a palavra e muito obrigada por ter aceito participar neste webinar. 5 minutos, por favor, não temos muito tempo. Obrigada.
Combinado, muito bom dia. Vou partilhar então a minha apresentação. Ora, deixem-me ver se eu consigo compartilhar. Ok. Oi. Conseguem ver a apresentação? Ainda não, pois não?
Não.
Ok. Peço desculpa este contratempo. Eu julgo que você está aqui. Agora sim. Peço desculpa. Já conseguem ver, correto?
Sim, sim.
Ok. Pronto. Bom dia a todos. Em nome pessoal e da Unidade Local de Saúde de Barcelos, Esposende, gostaríamos de agradecer a oportunidade de participar nesta iniciativa e de partilhar com vocês os projetos que temos desenvolvido com base na ferramenta da estratificação pelo risco e de que forma nos tem ajudado a reformular os nossos cuidados de saúde. Faço um breve enquadramento da população que assistimos. Nós temos cerca de 161 mil inscritos, para os quais temos 92 médicos de família, o que se traduz numa cobertura de praticamente 100% da nossa população. A estratificação pelo risco é uma ferramenta que permite agrupar os nossos utentes em níveis de risco e, por conseguinte, definir prioridades na sua abordagem. Não quero com isto dizer que os doentes de risco muito alto são mais prioritários do que os doentes de baixo risco, mas sim que em cada grupo esta ferramenta permite identificar janelas de intervenção que se vão traduzir em ganhos para o doente e maior eficiência dos nossos serviços. A nossa equipa de estratificação pelo risco reúne mensalmente e tem trabalhado em alguns projetos que vos apresento de seguida. No caso dos doentes de risco muito alto, são doentes do topo da pirâmide, que apesar do seu reduzido número, cerca de 3.000 utentes, têm um peso significativo no consumo de recursos. Desta forma, no consumo de recursos. Desta forma, nós podemos verificar que dos doentes de risco muito alto, eles consomem cerca de 10% da nossa despesa. Quando analisamos estes doentes mais a fundo, cerca de 2.950 utentes, nós encontramos que mais de 40% destes utentes têm internamentos evitáveis, o que nos leva a uma segunda questão. De que forma é que posso ajudar estes utentes em ambulatório para não descompensarem e quais devem ter prioridade na referenciação aos cuidados de saúde primários para uma estratégia mais dirigida? Consideramos que os utentes com mais de um internamento e com elevada probabilidade de internamento a 6 meses sejam prioritários e é esta amostra que referenciamos para a respectiva unidade de saúde familiar, onde atualmente estamos a instituir o projeto de Plano Individual de Cuidados. No centro de saúde, o médico e o enfermeiro gestor de caso fazem um diagnóstico de situação e, em articulação com uma equipa multidisciplinar, aplicam um plano individual de cuidados focado na qualidade de vida e no envolvimento do doente e da sua família. Outro projeto em curso é a reconciliação terapêutica, que em alguns casos poderá ser mais uma racionalização terapêutica. Quando analisamos os doentes mais frágeis, dos doentes de risco muito alto, à volta de 400 utentes, percebemos que a seguir aos internamentos, os medicamentos são o fator que mais pesa nestes doentes. Consideramos que é relevante constatar que são doentes com mais de 10 substâncias ativas prescritas, mas que ao mesmo tempo padecem de elevada dependência, mais de metade destes doentes. Neste sentido, questionamos se não haverá lugar aqui para uma equipa dedicada à simplificação terapêutica com critérios de stop and start, que promova apoio domiciliário e na gestão e monitorização dos medicamentos e eventuais interações. E estamos a trabalhar nesse sentido. Há pouco falávamos de internamentos evitáveis. A título de exemplo, nos doentes com internamentos por insuficiência cardíaca com fração de ejeção reduzida, uma percentagem relevante destes doentes não tinha seguimento por cardiologia e é algo que temos que melhorar. Nos doentes com diabetes, para além de monitorizarmos a hemoglobina glicada a cada 6 meses nos centros de saúde, não poderiam estes doentes integrar um projeto de telemonitorização e, através da avaliação mais regular da glicemia, não poderíamos identificar necessidades de ajuste terapêutico mais atempado e identificar precocemente descompensações? O mesmo para os internamentos recorrentes por pneumonia. Nestes doentes seria útil a referenciação para a equipa de telereabilitação que apostasse na cinesioterapia respiratória em articulação com o plano individual de cuidados. Com provas dadas são os projetos de telemonitorização dos doentes com DPOC. Atualmente, o grupo de estratificação pelo risco identifica os doentes com múltiplos internamentos com DPOC agudizada e referencia-os para o grupo de trabalho, que vai promover um acompanhamento mais próximo do doente, através da aplicação Telemonite SNS 24 do lado do doente e a plataforma de telecuidados a nível institucional, onde criamos um centro de monitorização. Por último, temos os doentes hiperfrequentadores do SU, onde identificamos 2.046 utentes, dos quais 42% são doentes com menos de 18 anos. Curiosamente, as admissões destes doentes são na maioria evitáveis, por se considerar que correspondem a doença ligeira e que está comprovado pelo reduzido taxa de internamentos associada a estes eventos. Para uma média de 7 admissões em SU, 5 são consideradas evitáveis. Para além disso, a maioria tem médico de família, pelo que uma segunda análise se torna mandatório, de forma a perceber a frequência e padrões temporais no acesso ao centro de saúde, perceber quais as dificuldades no acesso e, eventualmente, estudar estratégias de telesaúde que sensibilizem e tranquilizem os nossos utentes a recorrer aos cuidados de saúde primários. Em conclusão, a ferramenta da estratificação da população pelo risco permite identificar grupos de risco e direcionar estratégias e os nossos recursos para aquilo que se vai traduzir num real ganho em saúde. E o facto de permitir uma monitorização contínua e dinâmica que nos permite ajustar e melhorar continuamente. É óbvio que para isso é necessário ter uma base de dados fiável e ainda profissionais motivados e disponíveis, pois só assim existirá uma articulação multidisciplinar bem-sucedida. Devemos também salientar o nosso Conselho de Administração, que reconhece a importância desta ferramenta e tem tido um papel fundamental em garantir condições para o desenvolver. Muito obrigado.
Muito obrigada, José, e muitos parabéns pelo trabalho que têm vindo a desenvolver. E passamos já de seguida para a OLS do Litoral Alentejano. Vai apresentar a Inês Vale, que é médica de família numa das unidades de cuidados primários da OLS do Litoral Alentejano e vai apresentar o percurso da multimorbilidade. Obrigada, Inês.
A todos. Enquanto tento aqui compartilhar a apresentação, quero cumprimentar todos os presentes e agradecer o convite que nos foi endereçado pela vossa organização à Unidade Local de Saúde Litoral Alentejano, para nós, no fundo, partilharmos a nossa experiência na criação do nosso percurso assistencial de multimorbilidade. Portanto, eu vou falar um bocadinho do nosso contexto local, de como é que pusemos em prática a implementação e alguns resultados que já dispomos. Portanto, nós trabalhamos nesta região de Portugal, que é uma área muito extensa geograficamente, de aproximadamente 100.000 habitantes, sendo que mais de um quarto da população é envelhecida, o que já nos vislumbra alguns desafios em termos de multimorbilidade e complexidade nestas pessoas. E, por outro lado, lidamos com uma dificuldade nos recursos humanos. Somos uma área composta por um sistema que tem um hospital, centros de saúde. No início, quando começámos o projeto, tínhamos apenas apoio de um cardiologista e uma pneumologista a tempo parcial. E hoje temos cerca de 23% de pessoas que ainda não têm médico de família. Portanto, o que já nos faz sentir alguma necessidade de mudar a forma como prestamos os cuidados. Em 2020, a nossa Unidade Local de Saúde adotou a boa prática do País Basco, que já foi hoje partilhada aqui, no âmbito da Joint Action Jade Care, e com o apoio também do nosso Conselho de Administração, começámos um trabalho de reuniões locais, múltiplas reuniões, onde incluímos não só os médicos, os enfermeiros do hospital e dos cuidados de saúde primários, mas também os próprios doentes, os cuidadores, psicólogos, assistentes sociais e também farmacêuticos da comunidade, não é? Porque não podemos desenhar este projeto sem que todos os intervenientes partilhem também as suas opiniões. Deste grupo de trabalho criou-se o que nós chamamos o núcleo de trabalho, que de acordo com toda a coprodução que foi feita no passado, desenhou um documento de consensos e também decidiu os critérios de elegibilidade. E nós decidimos que os utentes para este projeto teriam de ter pelo menos 2 destas patologias: insuficiência cardíaca, doença pulmonar obstrutiva crónica e diabetes tipo 2. Muito importante foi também termos organizado as equipas de ligação, que são equipas de médicos e enfermeiros, que existe uma por cada centro de saúde e uma no hospital, que comunicam entre si. Cada equipe de ligação tem o seu próprio telemóvel ou e-mail, que é utilizado para garantir a comunicação não só entre os profissionais, mas também com o doente. Portanto, este número de telefone é para com os doentes e existe um horário em que os doentes podem contactar a sua equipa local sempre que haja uma dúvida ou algum agravamento ou alguma situação diferente. E assim garantimos a acessibilidade e a comunicação. Estas equipas de ligação resolvem também mais de 95% dos casos de descompensão por estas patologias de forma remota, muitas vezes fazendo pequenos ajustes. Em seguida, pegámos nas listas de pessoas que eram elegíveis para entrarem no percurso e com a colaboração de uma startup portuguesa começámos a desenhar a nossa jornada digital, que compreende aqui algumas coisas. Em primeiro, digital das pessoas, portanto, em tempo real, sabemos onde a pessoa se encontra no seu percurso e com caráter também interoperabilidade com os outros sistemas de saúde que usamos. Também um sistema de algoritmos de suporte à decisão, que podem ser usados por todos os profissionais que lidam com estas pessoas, e um sistema de envio automático de questionários de sintomas aos utentes ou aos cuidadores. Em outubro de 2023, entramos então no Go Live e a partir de aqui começou-se a apresentar o projeto individualmente, quer às pessoas, quer aos seus cuidadores. Foi explicado todo o processo, como é que iria funcionar, para termos aqui algum sucesso. Só de uma forma muito geral, os resultados que temos no fim de um ano de implementação. Temos uma redução de episódios de urgência de 46% numa cohorte de aproximadamente 500 pessoas que ingressaram, com significância estatística, e também uma tendência à redução das hospitalizações por estas patologias em cerca de 48%. O mais importante ainda é sentirmos que fazemos a diferença na vida das pessoas com doença e também nos seus cuidadores, que podemos trazer mais confiança e capacidade de lidar com os sintomas e com todo o percurso das próprias doenças. E era tudo. Obrigada.
Inês, muitos parabéns também pelo trabalho que têm vindo a desenvolver, e muito obrigada por participar. Vamos avançar agora. Melita, would you like to explain the breakout room?
Indeed. I want to first thank our presenters from Portugal. I really enjoyed these two presentations, and there was such an interesting connection between them that the more we move towards data-driven approaches, the more powerful we become to tailor services. But it becomes even more important to create processes that are participatory, that allow co-creation, to validate that the data-driven approaches that we designed, which are scientifically sound, are also tailored both to the people and to the caregivers. So I think this is a very interesting avenue to keep exploring. And now we would like to invite you to join one of 3 breakout rooms for the next half hour, where there will be a rapid fire opportunity to share your comments, your views, your own experiences. In breakout room 1, we will be focusing on care pathways for the complex patients with multimorbidity. In breakout room 2, we will be talking about both vertical and horizontal integration and what it implies for information solutions. And in breakout room 3, we will focus on the community, working together at the community level, the different actors we need to bring together. Our speakers will also be joining us, but you will have a chance to speak in your own language, and I hope we'll have a good participatory approach. We'll have 30 minutes, after which we come back for a quick wrap-up. See you in the breakout rooms. Maybe while you're joining it, you can see in the banner on the bottom of the page a sign, Join Breakout Room. If you click on that, you can join the breakout room you'd like. If you have trouble, please stay online, use the chat, and my colleagues can guide you to the relevant breakout room. See you over there.
Queria só voltar a repetir o que a Melita acabou de dizer, agora em português. Na barra inferior tem uns quadradinhos que permite, se clicarem, permite ingressar nas salas. Nós agora vamos ter umas salas onde vamos poder discutir e podem escolher uma destas 3 salas para discutir, e a discussão pode ser em português. Até já. Vamos passar aqui para um momento com um breve reporte daquilo que foram as discussões nas diferentes salas, e eu pedia ao João, ao Carlos e à Teresa que numa frase, porque já não temos muito tempo, portanto, que numa frase consigam fazer o sumário daquilo que foi a discussão nas vossas salas respectivas. Não sei se já estão cá os três. A Teresa eu vejo.
Sim.
João também. Carlos Galamba. Ainda não está. Bom, mas começávamos talvez pela Teresa, depois pelo João, e quando o Carlos se juntar, fará então também.
Então, muito breve, portanto, a nossa sala teve alguma discussão relativamente aqui à integração de cuidados e a grande conclusão é que não há um modelo fixo e que seja igual para todos, que temos muito a aprender com as experiências europeias e também dentro de Portugal a nível nacional, porque há várias experiências e as pessoas estão motivadas para, no fundo, em conjunto, partilharmos todas estas experiências para podermos crescer e conseguir a integração de cuidados, que é sem dúvida nenhuma fundamental e que tem e é obrigatório que seja todos em conjunto e com toda a comunidade, porque senão não irá funcionar.
Muito obrigada, Teresa, por esta super resumida sumário da discussão. Passava ao João para o João fazer o resumo daquilo que foi discutido na sua sala e, por fim, terminava o Carlos também com o resumo de uma frase breve sobre aquilo que foi discutido na sua sala. João.
Muito bem. Resumir numa frase será um pouco ingrato para mim, mas vou tentar. Então, de uma forma muito simples, devemos aproveitar a integração estrutural, que também já aconteceu em Portugal e que foi algo que trouxemos da apresentação da Reino, que faz todo o sentido, torná-la mais efetiva com o recurso a dados, nomeadamente à informação que a estratificação do risco nos confere, focar na doença crónica complexa, que esse era o nosso objetivo setorial do nosso grupo de discussão, e, acima de tudo, avançar. Começar por algum lado, começar pelas coisas simples e aproveitar as pequenas vitórias para motivar. E esta é uma das 3 palavras. A segunda palavra que vem a seguir ao motivar é confiança. Promover a confiança entre profissionais, entre níveis de cuidados e entre os profissionais e os doentes, garantindo sempre algo que chegamos à conclusão que no nosso sistema já existe e na nossa realidade, que é uma vontade. Não só uma vontade dos profissionais, e essa está lá desde o primeiro dia, mas também uma vontade política que me parece que existe, que está focada desde há alguns anos para a questão da doença crónica complexa e que continuará a estar, claro, sempre dando a volta e também à nossa boa maneira portuguesa aos desafios que nos vão aparecendo pelo caminho. Obrigado, Vanessa.
Muito obrigada, João. E por fim, passamos para o Carlos Galamba, por favor, não sei se está aí, peço-lhe que faça uma frase, eu sei que é difícil, mas tentar numa frase resumir aquilo que foi a discussão na sua sala. Obrigada. Não estamos a ouvir, não sei se tem mute. Não, continuamos sem ouvir.
Não sei agora já está.
Agora sim.
Ok. Então, destacaria a necessidade de muita determinação e empenho, e vi que a OLS de Barcelos o teve e o continua a ter, envolvimento de todos e a começar pelos conselhos de administração. De outra forma, nós não vamos ter estes modelos implementados em todas as OLS. Depois, grande preocupação com os dados, com o tratamento correto dos dados. Sem isso também não temos, sem informação fidedigna, não temos doentes bem acompanhados. E aqui, porque o tema eram os sistemas de informação, integração vertical e horizontal, ou seja, nós temos que ter ferramentas que deem resposta a todas as necessidades, não é só ao nível de ter um pathway, uma ferramenta que acompanhe o doente no seu plano individual, isso é importante, mas as ligações a todas as outras áreas dos cuidados de saúde, primários, hospitalares, mas também da logística da farmácia, até ao apuramento do custo por doente. Portanto, e aqui já entramos nas ferramentas da contabilidade de custos. Ou seja, sem esta transversalidade dos sistemas de informação, nós não vamos também conseguir chegar a bom porto.
Muito obrigada. Melita, would you like to have some final words?
Yes, thank you very much. I want to thank all the moderators of the groups to take us through in this whirlwind way of the discussions that have taken place. I am actually really impressed how much ground we have covered in an hour and a half. And I want to thank all of you for taking the time to be here and join us. At the height of the webinar, 140 of you were with us. And we know this is a really big time commitment out of your day. Some of you have to multitask. So thank you very much for that. This was our first webinar. We hope to learn from it. This is for you. It has to be helpful to you. So when we finish this webinar and you close the window, there will be a survey. And we would like you to take a minute to tell us what you liked, what you didn't like, how can we do better that these webinars serve your purpose? Would you like more or less, longer, more opportunities for conversations? We are interested in everything you have to say. And since there is still 113 of you, I hope to see 113 filled out questionnaires because your opinion really matters to us. I know we're giving you a lot of homework. I would just like to remind you that we really look forward to your responses to the PARA questionnaire. I think this will be really valuable input to the decision makers to see where you are in March, April 2025 in your implementation successes and with the challenges. I personally look forward to seeing it and feeding it back to you next time. Please sign up to the LinkedIn page of the project where you can follow about all the activities, the missions that are coming to you. We just finished a mission on looking into the governance arrangement of local health units. It will be followed by other missions about digitalization and health information. Each time we will be meeting some of the local health units, but not all of them. So please follow us. And in these webinars, we will also give you updates about the project, our joint project. And with that, I'd like to invite you for our next webinar, which will take place on April 25, just right after Easter, when we're fresh and rested. And today we spoke so much about population health management and risk stratification already. Next time we will dig even deeper into that topic from the perspective of implementation. What are the implementation strategies? How can you use population health management and risk stratification to really help you achieve your goals in your local health unit? See you on April 25, and thank you so much for this great interaction today.